The NHS England guidance on weight loss injections currently kind of doesn't apply to most people. It applies to what I would class as the most at risk and the most at need, who wouldn't immediately qualify for it potentially. So the reason I say that, a lot of these patients who have very high BMIs, who are already known to be diabetic, in principle, they could have already had the treatment. Because if you're diabetic with a high BMI, one of the drugs you'd be trying to add in quite early is a weight loss injection. Because not only are they good at controlling your sugar level, but they're also very good at controlling your weight. The only thing is, because of their cost, probably, we kind of can't use them first line. So we have to use them sort of third, fourth line often, in the way that the prescribing guidance is set out nationally and even regionally. So it might just be that they haven't made their way to it, and they might not know that they're entitled to it either. So hopefully it would help some of them skip the queue, and essentially it would help them. And what you will find is some of those conditions are very obesity related. So sleep apnea is directly tied to your BMI, and there are other risk factors for it as well. We know that your cholesterol level is relatively well linked to your BMI or your waist circumference. We know that heart disease has a correlation with cholesterol and obesity. So I think what they've done is they've looked at the things that are most likely to be related to someone's weight as the justification for prioritizing them. Now, the truth is, I think if your BMI is more than 40 and you have any one of those issues, nobody in the healthcare sector would have a problem with giving you that injection. It would be warranted. The reality is that would completely collapse the system. So, and I'm saying this very, very practically. Given that we haven't been able to use this injection in any capacity in primary care for weight loss at the moment, most of them have been out of stock for as long as they've been around. So that's the viewpoint that you have to look at this through. So if they made it very easy to access, it just wouldn't be available. You would very quickly run out of stock. And so the question is, if you're going to give a very defined cohort with reliability, if you're going to give them this medication in a reliable fashion, who is most at need? So I completely understand why it's been done the way it has. If I was a patient and I didn't fit this criteria, which most people wouldn't, I would be incredibly frustrated. If I was a healthcare provider and I wanted to be able to give it in primary care, which, by the way, I am one of, I am frustrated. But I completely understand. The healthcare system is free at the point of use. It has to be able to deliver to the most at need. And the plan is, over time, to roll it out in such a way where either the BMI restriction is reduced or either the amount of conditions you need is reduced. So there is a plan to open it out. I'm assuming behind the scenes there's conversations happening with the drug companies to see if they can perhaps increase the supply. So if we didn't have as many supply issues, and if some of these people perhaps weren't already using it in the private sector, we'd perhaps have more of it available. And it will probably be easier to give. But I think collapsing the system is very much the reason why it's being rolled out the way it has. Any time you are eligible for this medication in the context of weight loss, it's not without the lifestyle support. So if we were to look at the NHS England guidance, it's very, very clear. It says they can be used for weight loss, and unfortunately at the bottom, and perhaps this is the bit that patients might accidentally forget to read, it says in conjunction with a monitored and structured diet and lifestyle program, which is not the GP. So, GPs don't go through structured diet plans. Dietitians do that. They don't go through structured exercise plans. That's like your lifestyle coaches, your wellness coaches, etc. These are roles that are often funded through PCNs. So when we refer to NHS-funded weight loss programs, that's kind of the point. The point is they look at portion control, they look at diet advice, they look at weight loss, they look at exercise, and they support patients with that. With that in place, if the medication is still needed, that's the bit where it should be used. So what should be happening, in my opinion, is GPs should not be prescribing this medication at all, unless the patient is on one of these programs, is engaging with the program. And currently in our area, especially in Tameside, what we found is we have one of these programs in place, but they didn't have the prescribing team to be able to give the injection. So what should happen in our local area, as a very specific example, They should enroll on this program. They should follow the advice. We should have documented how well they're doing and how much progress they're making. And then a healthcare professional on that side of the team would say, this person meets the criteria for this injection. Could the GP issue it? And obviously the funding is provided, the training is provided, we know what we're doing. It's a commissioned service, as all services should be if they're being delivered by primary care. And then the GP issues the medication knowing there's a support structure around the patient. In terms of effectiveness, the drugs are incredible. There's no short version. There's no shorter version of that. Without falling into sort of conspiracy theories of is the evidence really that good? Because that's how good the evidence looks. It almost looks too good in terms of what they do. So not for Mounjaro yet, because it's not been around long enough to have the long-term data. But some of the earlier drugs, like liraglutide, which is Saxenda, or semaglutide, which was the Wegovy, the long-term data isn't just for sugar control of HbA1c or weight loss. It's actually in reduction of cardiovascular poor outcomes. So they are independently shown to almost sort of prolong life expectancy, reduce the risk of cardiac events, reduce your risk of having MIs, heart attacks and things like that. Now, what has been demonstrated is the newer drug Mounjaro, which is relatively specifically what the actual guidance is for. It's not sort of saying, start all these older versions. It was quite clearly, let's go with Mounjaro, which is how I interpreted the guidance. That doesn't yet have the evidence for long-term cardiovascular benefit. It does have the evidence for weight loss, and it does have the evidence for sugar control, and it's currently being demonstrated to be superior to the existing medications out there. That's my understanding of the data. I'm not a national expert per se in weight loss. I don't have a private clinic that I run. I don't have any sort of financial incentive here. But my understanding is, if you wanted to achieve weight loss, you would want to have Mounjaro, and if you wanted to achieve A1C control for your diabetics, you would want to use Mounjaro. As a separate question, knowing that it hasn't yet got the long-term outcome data for cardiovascular prevention, if we are finding very high-risk patients who have these cardiovascular risk factors, should we be giving them Mounjaro? Or should we be giving them the medication that have the long-term outcome data? I'm conflicted on that. And the reason is, you can infer that because it's better at reducing BMI, because it's better at reducing A1C, in principle, it will probably have the same, if not better, outcome data. But we tend to not make decisions that affect millions based on guessing. We should be making it based on facts. And I would say, if we were rolling this program out, which we are, we should probably be using Mounjaro for weight loss and for A1C control. I would have really liked to have seen a cohort of patients selected that had very high risk of poor cardiovascular outcomes, and I would have wanted them to have received the other medications, which have the proven safety data, with an agreement that when Mounjaro gets that same level of data, we transfer them over, which I'm sure it will. But I feel that I find that inappropriate. I would have preferred for them to have the drugs with the proven track record.